Good afternoon, ladies and gentlemen. It's my pleasure to welcome you to this session entitled, Should we be paying more attention to the environment in preventing healthcare-associated infections? I'm Giorgio Zanetti from Lausanne, Switzerland, and it's my pleasure to co-chair this session along with my colleague, Dr. Silaji. I hope I'm not destroying your last name. Okay. Without any further delay, it's my pleasure to introduce the first speaker, Professor John Boyce. He's Chief of Infectious Disease and Hospital Epidemiologist at St. Raphael Hospital in New Haven, Connecticut, and a Professor of Medicine at Yale University. He published a lot of pivotal papers in this domain. You are past president of SHE, right, as well, so a very distinguished speaker to introduce this topic today. Thank you very much, Professor Boyce.
Thank you. Good afternoon. I've shown a few pertinent disclosures on this first slide here. So for the environment to be considered important in transmission of pathogens, there are several things that have to take place. There has to be environmental contamination with some frequency. The pathogen must be able to survive in the environment. There must be transmission of the pathogen, either directly from environmental surfaces and equipment or contamination of healthcare worker hands following contact with environmental surfaces. And then if the environment is in fact important, then improved cleaning and disinfection of environmental surfaces should result in reduced transmission. Well, what about the frequency of contamination? With MRSA, the percent of surfaces contaminated with MRSA varies among patients depending on which body site they're colonized or infected at. So for example, for patients that are only colonized in their nose, maybe only 6% of surfaces would be contaminated with MRSA. 36% of surfaces have been shown to be contaminated if the patient has MRSA in a wound or urine. And then we found that 59% of surfaces were contaminated if the patient had heavy MRSA GI tract colonization and was having diarrhea. In a study in Baltimore, 19% of surfaces in an outpatient clinic were contaminated with community-acquired MRSA. Environmental surfaces in VRE patient rooms frequently become contaminated. In a study we did, 46% of surface cultures were positive if the patient had diarrhea for any reason. In contrast, only 15% of surfaces were contaminated if the patient had no diarrhea. In a study by Bonton that involved almost 1,300 cultures, 12% of those cultures were positive for VRE, but he noted that up to 60 to 70% of cultures were positive in the rooms of patients that were colonized with VRE at 3 or 4 different body sites. Weber found in a review of the literature that anywhere from 7% to 29% of environmental sites were positive in areas housing VRE patients. This plate you see here, all these colonies on here are VRE colonies that we cultured by moving a moistened swab over a patient's bedside rail. So when the healthcare worker comes along and they put their hands on the bedside rail and say, "Hi, Mrs. Jones." They can get VRE all over their hands just by doing that. In patients with C. difficile disease, they often contaminate their environment. In fact, if you go to rooms where there hasn't been any recent C. diff patient, only maybe 3 to 8% of surfaces would be positive, and that's from a previous patient. Rooms of patients that have asymptomatic C. difficile colonization result in anywhere from 7 to 29% of cultures being positive. And then rooms of patients that are having C. diff diarrhea results in 20 to almost 50% of cultures being positive. I hope I don't hang myself with this thing. Can you hear me any better now? Some other organisms of concern are, as you know, Acinetobacter and norovirus. This slide shows some of the sites that are commonly contaminated with this kind of pathogen, including bedside rails, bedside tables, blood pressure cuffs, and then some less commonly contaminated items like IV pumps, nurse call buttons are shown down here. Some investigators have even found small amounts of feces in the bed control buttons or nurse call buttons. Now, the pathogens also have to be able to survive in the environment, and you can see on this table that MRSA isolates can often survive from anywhere from 2 to 9 weeks on dry surfaces, VRE from 1 to 12 weeks, C. difficile spores from days up to 5 months, and then Acinetobacter from 3 days to a month, and norovirus from some hours to as much as 10 or 12 days. Now, environmental surfaces can act as sources for hand hygiene or hand or glove contamination of healthcare workers by organisms like MRSA, VRE, and C. difficile. And the frequency of C. difficile hand contamination actually correlated with the level of environmental contamination in at least some studies. Duckrow and colleagues did a study where healthcare workers touched VRE positive sites. So sometimes what they did is they touched a patient that was known to be colonized with VRE, or they touched some kind of environmental surface that was contaminated. And then those healthcare workers touched 151 VRE negative sites after they'd touched that known positive site. And VRE was transferred to about 11% of those negative sites. And in fact, what they found was that touching a contaminated environmental surface resulted in transfer of VRE to another site about as commonly as touching a colonized patient. Acquisition of pathogens from the environment or contaminated equipment has been seen, at least in a few instances. Contaminated electronic thermometers or their thermometer probes have been implicated as sources of several VRE outbreaks. In one outbreak, a contaminated EKG lead was the source of continuing transmission. And in these studies, molecular typing confirmed that the genetic relatedness of VRE that had been recovered from the equipment and from the affected patients. Bonton did a study in an ICU that revealed that 3 of 13 patients who were VRE negative to begin with became positive after their room became contaminated with VRE. And 2 of the 10 VRE negative patients whose bedside rails became contaminated acquired the same strain of VRE that was on their bedside rail, suggesting that the patient may have actually gotten it from the bedside rail. Healthcare workers that have no direct contact with a colonizer infected patient, but touch bedding or other objects in the room can contaminate their hands. And the frequency of hand contamination increases with increasing environmental contamination by Clostridium difficile. In another study, healthcare workers were shown to contaminate their clothing. In fact, 19% of nursing uniforms were contaminated with C. difficile after caring for affected patients. However, I think it's fair to say that the role of contaminated uniforms in transmission of C. difficile has really not been determined at this point. There's been several outbreaks of contaminated thermometers that have been implicated in transmission, and in one study, they found a correlation between the degree of environmental contamination and the incidence of Clostridium difficile-associated disease on one ward, but not on one of the other wards in the same hospital. Now, in the last few years, there's been an increasing number of papers that relate to acquisition of pathogens from the prior room occupant. In these studies, admission of a patient to a room previously occupied by a patient that had VRE, MRSA, C. difficile, multi-drug resistant Pseudomonas or Acinetobacter were significantly at increased risk of acquiring the pathogen. Transmission to that newly admitted patient presumably occurs either via healthcare workers who contaminate their hands by touching contaminated surfaces in the room, or maybe by direct transmission from environmental surfaces to the patient. And as you know, there's plenty of data, and Stephanie Dancer or Dr. Dettenkofer may mention that there's a lot of evidence that at the time of discharge, patients' rooms are not cleaned adequately. And so these pathogens are still sitting in the room when the next person gets admitted. Now, again, if the environment is related to transmission at all, then if you clean the environment better and you reduce environmental contamination, theoretically you should be able to show a reduction in transmission. So Mayfield and colleagues did a before-after study of C. difficile diarrhea on a bone marrow transplant unit that had quite a high incidence of C. difficile diarrhea. And what they did is they changed from use a quaternary ammonium disinfectant, which has almost no activity against C. difficile spores, to a 1 to 10 dilution of sodium hypochlorite or bleach. And they found that this switch from the quat to bleach reduced C. difficile diarrhea significantly. And then they changed back to the quaternary ammonium, and when they did that, the incidence of C. difficile diarrhea went back up again. It's interesting also to note that using bleach on a ward that had a very low incidence of C. diff didn't seem to have much impact. And I'm presuming that that's probably because there wasn't much environmental contamination on that ward. Stephanie Dancer conducted a prospective intervention study with a crossover design on 2 study wards in a hospital. The intervention was that an additional housekeeper was put to work on 1 ward at a time for a period of about 6 months, and then there was a crossover. 10 hand-touch sites were sampled weekly, and patients were monitored for MRSA infection. And what she found was that during the intervention, there was about a 33% reduction in contamination of those hand-touch sites, and there was about a 27% reduction in new MRSA infections when the ward was receiving the enhanced cleaning. Mary Hayden and colleagues did a very nice prospective 9-month study in a medical intensive care unit that included admission and daily screening of patients, and then environmental and healthcare worker hand cultures done twice weekly. The study design included a baseline period, that was phase 1. Then phase 2 was an education and monitoring and feedback that were given to the housekeepers about how they were doing and the importance of their job. Then there was a washout period with no specific intervention. And finally, a multimodal hand hygiene intervention. And what they found is that environmental cleaning rate, which is shown in these green bars, increased significantly from the baseline to the second period and was maintained throughout due to education and feedback of healthcare workers. They also documented that VRE environmental contamination decreased significantly as cleaning improved. And then importantly, as shown in this red line, VRE acquisitions by patients decreased significantly. And when they looked at other potential confounding factors, they really didn't feel that any of those other factors could explain this decrease in VRE acquisition. And they concluded it was really improved cleaning and reducing environmental contamination that resulted in decreased transmission to patients. In a 10-month prospective trial that we did, we used a before-after intervention study design. After patients were discharged, environmental surfaces were cultured for C. difficile, MRSA, and VRE, and then the rooms were decontaminated using a hydrogen peroxide vapor technology. And then the same surfaces in those decontaminated rooms were cultured again. And then we looked at nosocomial C. difficile diarrhea rates. And here's what we found. During the trial period, the incidence of C. difficile nosocomial diarrhea cases, as shown on the y-axis here, was reduced substantially during the trial period as compared to the 10-month pre-trial period, although this difference did not meet statistical significance. But this was a little bit of an unfair comparison because we knew that during the entire trial period, that new strain, the NAP1 strain of C. difficile, was present in our hospital, and we have reason to believe that it was not present during most of the 10-month pre-trial period. So when we confined the analysis to only those months during the before trial period and during the trial period, when we knew the epidemic strain was present in both time periods, then we found actually a statistically significant reduction in the incidence of nosocomial C. diff diarrhea. More recently, Passaretti and colleagues at Hopkins looked at the impact of hydrogen peroxide vapor room decontamination on the risk of acquiring VRE or MRSA. Now, in this prospective study that was done on 3 intervention wards, rooms were cultured for VRE and MRSA. Then the rooms were decontaminated with the hydrogen peroxide vapor whenever possible, so they couldn't do it all the time. And then they looked at the incidence of VRE and MRSA acquisition among patients who subsequently got admitted to those rooms. They divided rooms in the study into 3 categories. Missed rooms were those rooms where the preceding room occupant was known to be colonized with either VRE or MRSA, but for some logistic reason, the room wasn't decontaminated with the hydrogen peroxide vapor. Not done, this should be not done rooms, where preceding room occupant was not known to be colonized with VRE or MRSA, and the room was not decontaminated. And then the HPV rooms were where the preceding room occupant was known to be colonized with either VRE or MRSA, and the room got decontaminated with hydrogen peroxide vapor. And here's what they found. If you look in this second column here, this is the acquisition rate in terms of the number of acquisitions per 1,000 patient days. So in rooms where the prior occupant had VRE, but the room was missed, the rate of acquisition among subsequent patients was 10.2 per 1,000 patient days. In contrast, if the same kind of room was decontaminated with hydrogen peroxide vapor, the acquisition rate in subsequent patients was only 2 per 1,000 patient days, a statistically significant reduction. They saw a similar reduction when they looked at MRSA, although this reduction was not statistically significant. So in conclusion, environmental surfaces near patients frequently become contaminated with the patient's pathogens. These pathogens can survive for weeks or sometimes even months on environmental surfaces. The contaminated surfaces can act as sources of transmission, either via healthcare worker hands that become contaminated, or maybe even direct transfer to patients. And there are now a number of studies showing that improved environmental disinfection can reduce transmission of pathogens such as C. difficile, VRE, and MRSA. Thank you.
Thank you very much, Dr. Boyce. We have time for questions. If you have any, please proceed to the microphone, introduce yourself, and ask your question.
Oh, I knew Don had asked something.
There's not enough questioning going on, so I thought I'd stimulate questioning. So if you're a patient or a parent and you see this rich array of excellent epidemiologic studies, might you not ask why anybody would assume that it's okay not to clean a room adequately and the only real issue is how best to clean the room? In other words, shouldn't all the studies now, and maybe for quite some time, have been about the best way to decontaminate a room, not whether or not it leads to transmission of infection? It just seems like a almost beside the point question.
I couldn't agree more, Don. I think we're going to hear more about that probably during this session. As you know, getting rooms cleaned well on a daily basis and getting them well cleaned at the time of the patient's discharge, what some of us call terminal disinfection, is a tough job. And part of it's because of the extent of environmental contamination that can occur. But there's also the issue of getting housekeepers to routinely cover all surfaces that need to be decontaminated using the appropriate agent, and more importantly, using it for the appropriate time. And with the amount of turnover that is often seen in environmental services and their housekeeping staff, and the level of education, it's tough to get housekeepers to clean a room correctly every time. And so I think people are doing just exactly what you suggest. We're looking at ways to monitor cleaning so that we can start looking at how carefully people are doing their job. And then people are looking at new disinfectants, new ways of applying disinfectants, and even these more high-tech things like hydrogen peroxide vapor or ultraviolet light decontamination and some other methods where you take more of the individual variation between housekeepers out of the formula and you use some kind of technology that you know works on a reliable basis.
So I'll just make a quick reply. One of the things I believe we're discovering is that by incorporating housekeepers and maintenance people into the improvement team makes an awfully big difference. And I well remember when we were at an infection control conference in Colorado, the head of the housekeeping department came down to talk about how they manage their turnover, which is actually equally challenging. There's a certain time, a certain number of beds have to be turned, and for the reputation of that very high-end chain, it has to be perfect. And they walk around with devices and where they actually do random audits and checklists, and people are rewarded on the basis of the number of turns they do with the fewest defects. And when you ask the housekeepers, what do you think about your manager, they said, we love her because she respects us. And I think if we take that kind of attitude, I randomly stopped housekeepers in the hallway and I said, do you know, I think her name was Sylvia or something, do you know her? And they said, oh, we love her. So a little of that attitude instead of taking housekeepers out of the system is probably the way to go.
No, I agree entirely. Thank you.
Thank you for the comments. We have a second question. Please go ahead.
Sandy Barringer from Australia. I just would like to ask your opinion on, we're talking about rooms, but our patients do move into operating theatre, medical imaging, interventional suites, emergency departments, and a whole throughput of care. Is there a timeline in relation to the burden in the environment, or is it that we actually have to consider this standard? Because with the movement across, particularly in outpatient clinics and various areas of outpatient department management, if every room has to be cleaned for a patient with any of our MROs, our whole system will come to a standstill. So I don't know is there a rationalization of burden in the environment, or do we have to look at how do we maintain all these services all the time for all our patients? Because with the community disease coming into the system, it's not just the ones we know.
Right.
And therefore, what is your thoughts?
I think I understand the question. Actually, it seems like we have very little data on environmental contamination and on cleaning regimens in the outpatient setting. There's been a few studies with VRE and MRSA in outpatient clinics showing contamination. I think most outpatient clinics, well, many in the United States, will put down a thin paper on top of a patient table, and then when the patient leaves the clinic, they remove that paper and put on a clean one to try to cut down on transfer from one patient to the next. But I've actually seen very little data on how frequent contamination is and whether transmission occurs and the best ways to turn around a room. So I think this is a field where we need a lot more research, and it's a good point.
Mm-hmm. Thank you.
Yes, please go ahead.
Thank you for your presentation. The 2007 CDC isolation guideline implies that the new standard precautions measures involves disinfection of near-patient surfaces, if you read it with care. And I'd like you to comment, is that now the new standard precaution requirement that we disinfect frequently touched near-patient surfaces as a standard?
I'm not sure I understand the question. Do you mean disinfection as opposed to just
I'm
using
saying
a
the wording-
detergent, or?
Yes, cleaning and disinfection. The wording of the standard, as written in the 2007 document, says to disinfect.
Right.
But that is against every other statement of standard precautions that I've seen across the world. So,
Yeah, I think the intent was to say disinfection rather than just cleaning, for instance, with a detergent. And I think there's been a difference of opinion on this between the people in the U.S. and some of my colleagues in Europe, for instance, who feel that probably just a good detergent cleaning, or nowadays maybe a good cleaning with a different kind of cloth or mop may achieve relatively good removal of pathogens. But I think in the U.S. the feeling is that we'd rather use a disinfectant rather than just a detergent, especially if we're worried about pathogens like VRE MRSA.
We will take the last two questions, but please make it short.
From Turkey, and in our intensive care units, MDR, Acinetobacter is very prevalent, and we don't have enough isolation rooms, and we have open wards. How often do you prefer to clean, to disinfect the ICU in a day? How often can we do this disinfection?
Okay, I think this is highly variable from one hospital to the next, based partly on their structure and whether they're open wards or individual rooms. And even among hospitals with similar structure, there's a lot of differences in terms of their frequency of cleaning. Just to give you one example, in a large hospital in St. Louis, in their ICU, when there was a patient discharged with resistant Acinetobacter, the epidemiologist, who's a good epidemiologist, required that the room be bleach cleaned and then cultured, and then bleach cleaned again, and then cultured again before he let anybody, new patient, get admitted to the room. And in doing so, they would tie up a room, have an empty bed there sometimes for several days. Now, that's kind of at one end of the spectrum. At the other end, I'm guessing that in some places, they go in and they have a housekeeper do a standard quaternary ammonium cleaning, and they're out of there in 10 minutes. So it's everything
Please.
in between.
I will take the last question if you agree.
Have you also, my name is Beat Fasnacht from Switzerland, have you made experience in other places in hospitals, like in restaurants, cafeterias, waiting rooms, vending machines, drink vending machines? And are you applying in your hospital some kind of control system with contact slides or Eiger plates on a system like critical control points that you have determined before?
I don't know the first thing about vending machines, restaurants, or that kind of thing. I haven't done that kind of work. To your second question, for a couple of years now, we've been doing some studies with auger contact plates to look at environmental contamination before and after either daily cleaning or before and after terminal cleaning. And then we've also used ATP bioluminescence assays to look at levels of organic debris on surfaces before and after contamination. And actually, we showed, to Don Goldman's point, we actually, after we got the ATP readings, we went to the housekeepers and showed them the results, but we also talked to them about how important their job is. And so we are trying to do some monitoring of the cleaning process. Thank you.
Thank you very much, Dr. Boyce.